morning, everybody. It is Monday, June 14th, and this is our morning drive live. I want to talk today about a post over the weekend that got quite a bit of attention, actually, and is still getting comments as of this morning. And that was a post asking about no-show and late cancel codes and submitting no-show fees to insurance. So this kind of covers two different topics, but we'll talk about it like this. Yes, there are and there have been since I believe it was 2016 or 17 a code for when a patient no-shows for an appointment or when a patient cancels an appointment with less than 24 hours notice. And those codes are D9986 for the failed or the no-show appointment, and D9987 for the late canceled appointment. So a lot of people will say, well, wait, why are these codes here? Why do these codes exist? Why do we need them when we know submitting them to insurance, the insurance companies are probably not going to pay anything for them? And there's a few reasons for it, but we'll start with this. First and foremost, as we all know, when you are in network with an insurance company, the vast majority of contracts require that you submit all services performed or all codes walked out for that patient to the insurance company. So you are contractually obligated to submit those codes, even for services are non-covered, for services the insurance won't pay for because of a waiting period or whatever it may be. We are required by our contract to submit every single code for every single patient that has that insurance. So now that means the 9986 and the 9987, yes, we absolutely have to cancel those. Have to submit those because it's part of our contractual requirement. Remember, this is only if you are in network. If you are out of network, there is absolutely no requirement for you to submit any codes to any insurance company. But we'll talk about that in a minute. However, what that does mean is two things. Number one, the insurance company may limit your ability to charge a no-show fee or a late cancellation fee, a broken appointment fee, to any one of their patients. There are a number of insurance companies, for example, a Medicaid plan, will not allow you to charge a no-show fee to a patient. You can dismiss them. You cannot charge a fee to them for no-showing or canceling an appointment at the last minute. But there are other insurance companies that have that same policy. And when you submit the 9986 or the 9987 code to that insurance company, they may limit your ability or tell you, no, it is a $0 allowable fee. You are not allowed to charge the patient for that no-show appointment fee. It's just the way it is. When we're in network, we have to follow their rules. But, the vast majority of them will make it the patient's responsibility. It'll be a non-covered service. The patient will pay your UCR for whatever it is, and you're good to go. The other reason that these codes came into existence is because of a little tiny law that got slid in along with the Affordable Care Act which says if a patient fails to maintain preventative care, the insurance company does not have to, not that they won't always, but they do not have to cover restorative work or treating a problem. So here is a perfect example outside of dentistry. If you are a woman and you are of the age that they suggest you receive a mammogram every 12 months or every 24 months, and you fail to get a mammogram within the timelines that they suggest as being acceptable for preventative care, and then after 4 years of not having a mammogram, you are diagnosed with breast cancer, your insurance company doesn't have to cover any of the treatment or care for that cancer. Now, that's not saying that they 100% won't. That's not saying that all insurance companies follow that, but there are some that do. In dental, it is the same thing. If you fail to maintain your preventative care, and after 12 or 16 months of failed appointments, missed appointments, not going for your preventative care, your prophy, your exam, your x-rays, whatever that may be for you, and you end up with the need for three surface fillings, the insurance company doesn't have to pay for those fillings. Not that they won't, but they don't have to according to the law. So, some insurance companies do follow that. Some insurance companies don't. It's a very selective, I honestly have no idea what the algorithm is. And I can tell you, I have seen I will say the past 4 years, I've seen it twice. 2 times I have seen the insurance company deny restorative care because the patient failed to maintain preventative visits. And what I will say is both of those were with risk-based plans. So they were with plans that were 100% risk-based, which, we've talked about what a risk-based plan is before. And I just want to put that out there. It's not a regularly occurring thing, but it definitely does happen and is possible. So I just wanted to let everybody know about that. I wanted to clear up the, confusion, any confusion there may have been over the weekend from the 9986, 9987 code post in the group. If you have questions, let me know. I'm absolutely happy to answer them. Other than that, I am here. Everybody have a great day, and I will see you guys tomorrow. Good morning, everybody. It is Tuesday, June 15th, and this is our morning drive live. I want to talk today about something that was posted in the group and has actually been posted in a few groups over the past few days, and that is the storing of EOBs, but we're going to take it a step further and also talk about documents in general, because storing EOBs and digital records, electronic copies of documents, is something that a lot of people are concerned about because you're not maintaining the original copy. However, you don't need to, because federal law recognizes digital copies of documents, electronic copies of documents, as well as electronic signatures as legally binding in all 50 states. So obviously, when we talk about digital documents, they have to be unaltered. But, with us, we have to deal with HIPAA. So what that means is you have to store the entire document. So, we do run into some issues where people will take a screenshot, especially if it's a bulk EOB that has a lot of patient's information on it. They will take a screenshot of just the patient's part of the record. And that is not acceptable because you have to have the entire document. But what is acceptable is having the entire document and then blocking out the other patient's name, subscriber ID, dates of birth, whatever may be on that EOB that identifies a different patient. So screenshotting just the little box that has that patient's information on it is not acceptable because you do need the entire unaltered document. But because we have to comply with HIPAA, you can black out the other patient's information. So, that's number one. We have to make sure we're doing that. Number two, we also have to remember once you scan those in, they become part of the patient's record, which means when the patient requests a complete copy of their records, any EOBs that you have stored electronically are included in their record set, are included in what you have to provide to them when they request a full copy of their records. So, how we kind of not get around it, but keep the EOB out of the patient's record set is by not uploading each EOB directly into the patient's Smart Doc or Doc Center or Images folder, but creating a separate network share folder that's stored on the server for just EOBs. So then we'll scan in all the EOBs for today. We would name that document June 15th, 2021. We'd put it into the 2021 folder on the network share folder that's named EOBs. That way we can very quickly, very easily access it if we need it, but it's not in the software, so it doesn't become part of the patient's record. It's not in their record. It's not in your Dentrix or your EagleSoft or your Open Dental or wherever. And it doesn't become part of their record. So those same rules don't apply because then it is the office's record. It's not part of the patient's record. Hopefully that makes sense to everybody. But once you have confirmed that the scan you made is accurate and complete, you've made sure it's not missing any pages. If you scanned 52 pages, that the scanned electronic document has 52 pages, you confirmed it's accurate and it's authentic and it's saved. That's the important part. It has to actually be stored and it's not, not messed up. The document isn't broken. There's no fragmentation or anything within the document. It's a good document that you can open, view, and use. Then you can absolutely 100% get rid of your paper copies. There's absolutely no reason to keep paper copies of EOBs for any length of time, whether it be 1 day or 10 years, once you confirm that you have a valid working electronic copy. Electronic copies of records are valid, court legal, completely 100% okay in all 50 states. You don't have to have the original. There are some documents that you need to have the original for, but not in a dental office. Even medical records complete medical records. Once you have a good digital copy, you do not need to keep the paper copies anymore. Now, those things that you do have to keep originals of are things like wills, property deeds, things like that. There is nothing in a dental office that you have to keep a paper copy of. Electronic is 100% acceptable, and electronic signatures have been acceptable for years and years at this point. There is no reason not to have electronic copies of everything. So, I want to make sure everybody is aware of that. I know there was a post with some confusion that people saying, well, once it's scanned in, don't you still keep the paper? The problem is with paper EOBs, they now have to be kept under locked storage. They can't just be in a filing cabinet that is not locked, just like all of your other paper records. They have to have accessibility controls, limited exposure, people, limited access to them. Not just anybody can open up the document, open up the file, and see what's in there. So you really have to keep track of all of that when you have paper, whereas when you have it electronically, it's all done for you. Those access controls, the access logs, everything is done electronically, so it's just so much easier. So hopefully that makes sense to everybody. I am here. That is it. Everybody have a great day, and I will see you guys tomorrow. Good morning, everybody. It is Wednesday, June 16th, and this is our morning drive live. And hopefully, the sound will work today. I want to talk today about third party administrators as related to insurance companies and network participation status, because there was a question in the group about it, and I just want to talk about that a little bit today. So, a third party administrator is a management group that has its own network of dentists and leases out that network, shares out that network with other insurance companies. So, for example, you can be in contract with or in network with MetLife directly. So, your contract is with MetLife, or you can be in network through Carrington, and you're still in network with MetLife, but you're in network with MetLife at the Carrington fee schedule, utilizing the Carrington fees. So, when we're working with an office to increase their reimbursements, one of the things we do is look at their contracts with third-party administrators. We look at those fee schedules, and we determine which insurance companies we're going to be better off going through a TPA, through a third-party administrator, than we are direct with the insurance company. But you have to remember there are some caveats, as there are with everything we do, in doing that. Number one, a lot of them will have a certain time during which you have to be out of network, or a waiting period to go in network through a TPA after you cancel a direct contract. So if you cancel your contract with Cigna directly to go in network with Cigna through Carrington, there's typically going to be anywhere between a 3 to 6 month wait, which means for those 3 to 6 months, you are out of network. Now, at the end of the day, it absolutely may be super advantageous for you to do that. And you're going to make up the difference over, a number of years by getting reimbursed more. So, but that is something you definitely have to be aware of, that, you can't say we're going to go out of network with Cigna on May 31st and in network with Cigna through Carrington on June 1st. It does not work that way. There will be a waiting period, and they all have that waiting period. It's just going to vary depending on the direct contract, the TPA agreement, and how long it takes for the two of them to process internally, well, intra-ernally between each other. So that's one thing you have to be aware of. The other thing you have to be aware of is a lot of insurance companies that have multiple levels of participation. You can only be in network with one of those levels of participation through a third-party administrator. So, for example, MetLife has PDP Plus and they have PDP. Some plans are PDP Plus, some are just PDP. If you are in network directly with MetLife, you can be in network with both the PDP Plus plans and the PDP plans. But if you are in network with MetLife through Carrington, for example, you can only be in network with the PDP Plus plans. You cannot be in network with PDP. So you may do a verification for a patient and it's MetLife and you're in network and you do the verification and everything is wonderful. And then you submit the claim and you get notice that you are out of network. And maybe that plan pays at a lesser percentage because it's an out of network provider. Maybe the deductible goes from $50 to $200. There's going to be some changes there, and you are now, because that plan is a PDP plan and you are in network with MetLife through Carrington, your PDP Plus only, you are out of network with that PDP plan. So, these are some things just to be aware of, some things to keep in mind when you're making the decision. You do have to look at the numbers. And, that's a big thing that we do, is look at those numbers and determine, okay, for this 90 days that we are going to be out of network, how many patients with those plans, how many patients with MetLife, how many patients with Cigna, how many patients with Aetna, whatever it may be, are we going to be seeing over that 90-day period that it's going to impact? The other thing you have to remember is for that 90 days, you're out of network. So if you are submitting your UCR on the claim form to the insurance company and they come back and say you're out of network, we're going to pay $50 towards the pro fee, but the patient's responsible for the other $65 that you put on the claim form, if you charged $115, then the patient is responsible for that. You've submitted it on the claim form. You've told the insurance company that's the amount you intend to collect. You can't just say, well, Mr. Patient, we're now going to write off that difference. We're now going to write off that $65 and we'll just take the $50 that insurance paid, because that would be overbilling and that would be a form of fraud. So, you can't do that. So if you are going to accept your previously allowed fees for that 90 days, you need to make sure those are the fees you're submitting on claim forms as well then. So hopefully that clears up a little bit about TPA. The one last question that somebody asked about it was, if we're in network with MetLife through Carrington and a MetLife patient calls, can we tell them we are in network? Absolutely, you can. You are in network with MetLife through Carrington. So, they're not going to understand all of that. They're not going to understand the TPA, but you will, and technically you are in network with MetLife for the PDP Plus plan only. So you have to remember those as well. So that is it. I am here. Everybody have a great Wednesday, and I will see you guys tomorrow. Good morning, everybody. It is Thursday, June 17th, and this is our morning drive live. Today, I want to clear up some questions that people have had about the periodontal codes and prophies and cleanings and deep cleanings and SRPs and scaling in the presence of gingivitis and so on and so forth. So let me preface this by saying I personally hate the term deep cleaning. It's not something that I use with patients. It's not something I train people to use with patients because all they hear when you say deep cleaning is cleaning. And then they wonder why their insurance isn't covering it at 100%. So I try to get away from that, and I use the actual terms, whether that's a periodontal maintenance, whether that's scaling and root planing, or I'll say we're actively treating your periodontal disease, whatever it may be. But in my opinion, when you say deep cleaning, patients hear cleaning, and they're used to that being paid 100% by their insurance. And then they get upset and annoyed with you when it is not. So I'll preface it by saying that. So we have to look at this from the beginning. So, a patient comes into your office, and we will say, just for clarity's sake, we'll say it's a new patient that comes into the office, and you are doing a comprehensive evaluation on that patient. So now, if the patient has so much calculus buildup that you cannot accurately complete a comprehensive evaluation, whether that's a DO 150 or a DO 180, the only code you can bill is a 4355 full mouth debridement. Excuse me. If there is so much calculus, you can't complete 6-point perio charting accurately. The only code that you can bill is a D4355 full mouth debridement. That is it. You can't bill out an SRP. You can't diagnose the need for a prophy. You can't do any of that. Because remember, whether it's a prophy, whether it's a 4346, scaling in the presence of gingivitis, whether it's an SRP, those all have to be diagnosed and prescribed by the doctor. And if you're not able to do accurate 6-point full mouth perio charting, you're not able to prescribe any of those. So you do the 4355. The patient comes back in 2 weeks. Now you are able to accurately perio chart, which now helps us in the diagnosis of, is this gingivitis, moderate to severe gingivitis, and the patient gets a 4346? Is this periodontal disease, and the patient gets scaling and root planing? Or does the patient have a healthy mouth and you're doing a prophy? So you have to be able to diagnose first, but we have to realize what the different codes mean. So we'll start, the post yesterday was, patient came in, we did a 4-3-4-6, scaling in the presence of moderate to severe gingivitis. Then the patient came back and we did scaling and root planing. The insurance denied the scaling and root planing, and we don't understand why. Well, here is the easiest way to put it. When you did the 4-3-4-6, 4-3-4-6 is scaling in the presence of moderate to severe gingivitis. So when you build that out, you're telling the insurance company and the patient that they do not have periodontal disease, they have moderate to severe gingivitis. Then the patient comes back and you do a 4-3-4-2 or 4-3-4-1, whatever scaling code it may be. And now you're saying, well, no, now 2 weeks later, or a week later, or a month later, now the patient has periodontal disease. And yes, of course, that's going to be denied because the patient can't have both. They have one or the other. It's just not possible for them from a clinical standpoint to have both. Because remember, if you have periodontal disease on one tooth, if you're doing a 4-3-4-2 on tooth number 2, and that is it, the patient has periodontal disease. Whether it's one tooth or 28 or 32 teeth, the patient has periodontal disease. So you can't do a 4-3-4-6 on a patient that has periodontal disease. The other side of that coin is if the patient really only needs a 4-3-4-6, it would not be appropriate to bill out or to do a scaling and root planing on a patient who doesn't really need it. There's a number of studies out there, clinical studies, that show when scaling is done unnecessarily on a patient who has maybe advanced or severe gingivitis, but doesn't have periodontal disease yet, according to the current definitions, that unnecessary SRP actually increases the chances for attachment loss and can actually be detrimental for the patient. So we have to remember to use not only the right codes for billing purposes, but the right codes for treatment purposes as well. If you have a patient who has moderate to severe gingivitis, 4-3-4-6 is the right code. If you have a patient who has periodontal disease, then scaling and root planing may be the appropriate treatment for them. But you can't then later go back and say, well, now this patient doesn't have gingivitis, now they have periodontal disease, or they have periodontal disease, now they have gingivitis. It's a one or the other situation. So hopefully that helps everybody. I am here. Everybody have a great day, and I will see you tomorrow. Good morning, everybody. It is Friday, June 18th, and this is our morning drive live. So, yesterday was a weird day for me. I was at my office, and everybody that came in to see me, every one of my employees, everybody that came in said, "Wow, are you okay today?" And, towards the end of the day, I kind of realized I wasn't okay. And that is because we hit a record yesterday that is not a record I was happy to hit. Yesterday, in one day, I got 30 2 Facebook messages from different people from all over the country saying, I think I have to quit my job. I think I have to find a new office. I think I have to find a new place to work because the office I'm at, they're doing this, they're doing that. They're waiving copays and deductibles for every patient and not notifying insurance. They are balance billing for night guards when we're in network and it's a covered benefit. And the EOB clearly says charge $300, but the doctor says I can't make any money at that, so just charge the patient the difference to our cash price, even though we're in network, even though we know we're not allowed to do that. And I got 32 of those messages yesterday in one day, not all at one time, but over the course of the day. And that was a record for me. I mean, I usually get 1 or 2 a day. And, that's normal. It's expected. It's going to happen. But I got 32 in one day. And it really got me thinking that, so many dentists are all over Facebook and all over everywhere. And everybody in every industry is saying, it's really hard to find people. It's really hard to hire people. We're having a hard time finding employees. My remote billing division of my company is getting phone calls every day from offices saying, we think we're going to need to outsource this. We can't find employees. We can't find people to work. And while I think part of that is probably due to the economy and the state of the world, and people, a lot of people are choosing to leave dentistry and so on and so forth. It really got me wondering how many of those offices can't keep the people that they can hire because they're doing things they know they shouldn't be doing. And it really just kind of got me thinking about the ethical conundrums that we run into every single day as employees. And, I have a very hard time looking at things from an employee point of view sometimes because I haven't been an employee since I was 19. I've been an employer since I was 19. So I have a hard time sometimes seeing things from the employee point of view. But that's why I have constant, ongoing discussions, meetings, reviews with my team, because I want to know their point of view. I want to know what their thoughts and opinions and feelings are about what we're doing as a company. And it's hard for me to get that zeroed in look about 1 or 2 specific things, the little details, what kind of keyboards we buy or what kind of mouse we use, because I'm looking at the 30,000 foot view and they're down at ground level looking at that view, and it's a totally different view. And, I just want to put out there, and, I'm glad this is happening on a Friday, because it will make it very easy to find when this gets posted to YouTube for people who aren't members of the group to be able to see this video right now and think for a minute about what they're doing. And, that doctor, and it wasn't one doctor, it was a couple doctors who said, I can't make money charging what insurance allows for that service. Balance bill the patient, even though we know we're not allowed and it goes against our contract. That $100 extra or that $200 extra that you're making is costing you the respect of your employees, Because if you're willing to break that rule, what other rules are you willing to break in order to turn a profit? And that is the point of view that an employee has and should have. And I, as a third party vendor, as an outsourced vendor, as a consultant, have the same view. So the view that you are giving your team and your suppliers and your vendors of yourself, is it worth that $100 or $200 income to permanently change somebody's opinion of you as a professional? And that really is what bothers me, is how many people, how many employers, how many dentists I heard yesterday are willing to sacrifice the respect of their team and the trust of their team in exchange for a couple $100, which at the end of the day, unless you're doing 2, 3, 4, 5, 6 night guards a day, or whatever it may be, dentures or whatever, you're not talking about a ton of money at the end of the year. And yes, I understand dollars add up. Pennies turn into quarters, quarters turn into dollars, dollars turn into $10 bills. I get it. But none of that is worth losing the respect of your team. And that is what is happening when you're telling them, I know this is the rule, but we're not going to follow it because I want the extra money. So, hopefully I can now get off my soapbox and not be as annoyed as I was yesterday with all of that going on and those constant messages all day. Don't stop sending me messages. If you have a problem, if there's something you need help with, message me. I'm here. That's why I'm here. I'm not saying this so that people don't message me. I want that to continue happening. But it just hit me hard yesterday that there are that many offices willing to trade the respect of their team for some money. So hopefully that'll help somebody. If you ever need anything, feel free to message me, ask in the group, whatever it may be. I am going to put this again. This is going to go up on YouTube this evening. I'm going to make sure the editors get it done quickly so we can get it up today. That is it. It is Friday. Everybody have a great, great weekend. And, don't forget about your fathers. And I will see you guys on Monday. Have a great weekend.